All right, welcome everyone to day 2 of IMSH 2022. I'm Lance Baily, your host for the PRESSBOX. I'm the founder and CEO of HealthySimulation.com. So excited to be partnering with the Society for Simulation in Healthcare through HealthySimulation.com to be able to provide some additional coverage of the event here. So the PRESSBOX is designed to help share the messages and the information, the resources, the networking, the lessons learned here from the event for perhaps those that could not make it to the show, or for perhaps those that are off doing some other things, so we could bring together more conversations in the space and kind of highlight some of the key successes that are taking place. Yesterday we talked about COVID-19 and the impacts that it's had on the healthcare simulation space. We've learned a lot about great lessons that are taking place in terms of expanded use of remote and distance-based learning technologies, the successes that those have had, not only for improving clinical outcomes, but also for bringing awareness and attention to simulation programs in a way that has never existed before. Not only for other clinical educators, but also to administrators of programs, C-suite executives, deans of programs, highlighting the powers of what simulation can do. So today I'm really excited to have with us joining Shannon DiMarco from UW-Madison, Elizabeth Wells-Beede from Texas A&M, and Tiffani Chidume from Auburn University, who have asked here today to kind of share some of the success stories that they have experienced over the last 2 years, or in a wider context, simulation as a whole, in a way for us to kind of combat some of the negativity that COVID has brought onto the world. We all know that things are working well with simulation in terms of one of the industries out there that has actually been able to kind of help and support and mitigate the challenges that exist out there. So welcome to all of you. Thank you so much for joining us here today. I'd love to hear a little bit about some of the things that have worked well for you all over the past couple of years, or with simulation in general over your professional career, just to share with others some of the things that you've seen out there that have translated. I've heard of stories, several stories out there of learners who went through a simulation experience, like CPR training, even as basic as that, and then boom, next week they happen upon a car crash accident scene and they're able to help save someone's life because of the training that they had just received in simulation. So I love hearing stories like that because it just directly ties it in. But of course, that's a very micro level. We could look at the macro level too here. What systemically is working out, in terms of simulation? So Shannon, we'll start with you, and just curious to know about, some of your work there and what people have been seeing as successful.
Sure, thank you. I'm excited to be here to talk about it a little bit too, and we actually have a story that's actually very similar to what you were just saying.
Oh, cool.
Back at the end of 2019, we had done an ECMO simulation, a transport simulation, and had worked with our EMS community to talk about how could we use this new ECMO simulator that we created in order to help with getting a patient on ECMO. And within 72 hours, we actually had a patient who had gone out for a night with some fun with some friends and had ended up face down in the water. And by the time EMS had gotten to him, he had a very, very weak heartbeat. Okay. And they called UW Hospital and they said, we're bringing this patient in, but we don't know what the sustainability of his life will be. And they said, nope, we're going to get our ECMO protocol up. We just tested this 2 days ago. Wow. And they brought him back, and he walked out of the hospital with very minimal life-sustaining injuries.
Oh,
so
my God.
It was very great.
That is so great to hear. The stories that are just like those, it's almost like just-in-time training. You
Absolutely.
know what I mean? It's something that took place, and I think that those kind of stories help to demonstrate to leadership, if we're going to be doing high-stakes clinical engagements, just how important refreshers can be, yeah, before we go into those experiences. For example, CVC insertion. And I know of one research product out of Northwestern that was utilizing Simulab products, and they had seen that if they'd done some just-in-time training, 88% reduction in lethal infection rates for CVC insertion. Ended up being a 7-to-1 cost savings. So that was just training that happened right before the actual clinical skill needed to take place, and it just helps to bring people back into that practice mode, especially with high stakes moments like this, or patient engagement opportunities. So I love hearing about those types of things. Elizabeth, how about yourself? Any of those types of success stories from your program?
I don't have anything as extravagant as that, but we've had a lot of opportunities to continue collaborating, and I think that's one of the biggest things that I think's been somewhat amazing about this whole thing, is that when you have areas of distance campuses, so yeah. I work for Texas A&M, but I'm not on the main campus, so I'm actually at a satellite campus, and so it's always been difficult to make some of those connections on the main campus to move simulation forward and to the next era that we're looking at. And so it's given me the opportunity and some students within the different departments within the university itself to collaborate and create some virtual reality simulations. And so we kind of looked at things on that cutting edge of how can we look in areas that aren't being explored currently. So it's been amazing that we've received actually federal funding to be able to do these grants, and so we're working on a few of them that we'll actually be presenting later on this week. So it's been, I think the collaboration, the presentation this morning was amazing to hear how we all need to learn how to speak now in this new digital world appropriately, and it really reminded me as well of the basic assumption. It was worded a little differently, but it was still the basic assumption of just how we need to communicate with each other better, and I think that's one of the big things for me.
Yeah, and so, you know, yesterday we heard from the presidents of ASPE outgoing and incoming, Sean and Robert, and they talked about how in some ways simulation has been a blessing because it has enabled for them to start to begin to do hybrid simulation, Zoom simulation, using standardized patients in a way that no one had maybe even thought of or considered or, you know, was interested in doing prior to COVID. And so in a sense, it has expanded the awareness that clinical educators and SB coordinators and program managers have seen about utilizing, you know, those particular tools to expand access to this learning content overall. So it sounds like this has happened for your program, and so a success of it is that we're seeing more people kind of become aware of what simulation can do.
Absolutely. Awesome. And I think it's funny because when you say that nobody else thought about it, I'm pretty sure any of us in this room, all simulationists at some point in time thought of how can we start doing telehealth via simulation.
Right.
It was a matter of people not really listening and supporting, and then now all of a sudden it all switched, and it was like, oh, how can we do this? And all of a sudden, oh, I could do it. So it was, I mean, that exciting part of it, I think, has been really amazing to say, we knew we could do this.
Right. And then, you know, for our community and our crowd, we're the folks that, you know, as early adopters, we're more willing to take risks.
Absolutely.
We're more willing to fail. We're more willing to bring in new technologies, learn how they can work, and then improve upon them over time. We've been, you know, double-edged sword that it is being, you know, early adopters. We also have to champion these technologies and these methodologies, right? We have to educate others, and we have to be willing to share. And so I think that, you know, we as a group have probably been one of the best prepared, you know, subgroups of healthcare for these dramatic types of changes, because we live in a world of trying to utilize and overcome challenges through simulation-based technologies. So Tiffani, thank you for joining us as well. And so I'd love to hear from you in terms of some of the amazing success stories or stories of inspiration that have happened at your program at Auburn.
Okay, sure. Thanks for having me, Lance. So one of our biggest things that we found out, and one of our pride and joys, is we had an end-of-life simulation that we ran using 2 standardized patients, one as the patient and one as the family member, and taking care of them. And we already found before COVID that the students paid more attention to taking off the orders that were on the physician order sheet rather than catering to that family member. So when COVID happened, we weren't face-to-face. Our university was shut down. My quagmire was, how do I get this empathy aspect to translate to our students?
Right.
So I wrote an end-of-life simulation based on the death of my brother-in-law and the questions that my sister had about this dying process and what's the difference between palliative care and hospice care, and, well, you know, what does hospice really mean? Is that really meaning like they're killing him? And I was like, no, and you need to make him a DNR. And she didn't understand, you know, like, well, that means I'm just gonna let him die. I'm like, well, he's already dying. Do you want them coming and doing CPR on him? She's like, no. I'm like, that's why you need to sign the DNR. So shameless plug, there's poster 105 in the Petrie Hall.
Great.
But I've written that up, and it's one of my projects. But we found that just having it based on a communication, a therapeutic communication with that phone call with the standardized patient, acting as the family member, calling to check on them, saying, do I need to come now? The students, they've broken down. Our SPs are in a role, and they are actually breaking down. A lot of the facilitators are, you know, having, you know, these moments of remembering when this happened to their mother, their grandmother.
Right.
So we had to provide for psychological safety for our SPs, for our faculty, and for our students. We gave the students an opt-out. None of them opted out of the experience. And it was more beneficial to them that they were just like, I don't know how I would have handled this conversation before. I've never had to give report to anybody else except for my nursing instructor or my nurse.
Wow.
So I've had to talk to a family member. Now I think I feel comfortable talking to a physician and even giving a patient an update on themselves about what's going on with them. So I think that their communication aspect really helped our students, and they are really appreciative of it. And that's just, and the big win here is that the course leaders, there are 2 for that course. One is a sim champion, sim in the classroom. One didn't necessarily care for sim. Both have opted to keep that virtual despite us being back face-to-face.
Wow.
So we're learning every simulation does not have to be face-to-face. There are a lot of good telehealth and telehealth communications.
Right.
So we base it on, telecommunication virtually, and how it can be effective for learners.
Right. And so, I think when we're forced to use a new framework to work through, and this is one of the things that I learned in film school, is if they give you the rules of what you have to work within, it's a silent picture. You can't cut. You can't use any audio. Whatever it is. Now your creativity starts to flow because you can't do this for sure, and you can't do that. Okay, well we can only do this. Well, what can we do in this space? And so by being forced to kind of look at how we can look at remote distance learning technologies, it's provided for new ways of kind of bringing those simulation experiences to life. I love what you said about telling a real life story and bringing that into the clinical training experience. In film and theater and script writing, we're told that if we can, base it off of real life experiences, obviously the narrative, rights to it to kind of modify, but it bases it on something that's a real experience. And that means that for you knew exactly what those words were going to be, right? Because you lived it and you experienced it and you had that loss and you were that person. And so it's in a sense, for us in the clinical education space who maybe don't have this background in theater and artistic kind of filmmaking, which is kind of what we do all the time, to bring in those unique skill sets and learn how to do that, I think is in a sense a blessing in disguise with regards to the effects of COVID, because it's all kind of given us these opportunities to think more about how we can relate as that patient or that nurse in those situations and bring those things in. To me, it seems like in all of these cases, it's kind of a level of success, for the program as a whole, but maybe doesn't necessarily translate that specific story to leadership for them to understand. I'd be curious to know, for each of you, how has simulation kind of increased in awareness or been kind of seen as a new opportunity for support in the future because of COVID? Any kind of successes with kind of improved awareness or support from administration over the past 2 years? We'll start with, sure, Tiffani.
I was at Auburn University. I think our university as a whole has realized that. So faculty always had this option to be on campus or not, depending on what the job entailed. But our staff actually, like our sim tech and our lab staff, they didn't ever have that choice. Our administrative secretaries, and they didn't have that choice to be virtual. And so when we actually were back face to face, they were kind of just like, hey, I got as much done at home, working from home, as I could being in the building. If I don't have to be in the building, I can still do my job. And so the university has done a pilot for 6 months, and now it has been approved that they're going to bring in more because there has been no loss of productivity university-wide. So they're letting staff work from home at least 2 days a week now.
Yeah.
So they are loving it because they don't have to be on campus. They can be in their PJs working from home, but they're getting the job done.
Right. And I think that brings up an important point about the power of hybrid learning and digital and remote-based technologies. We were all kind of aware of Skype or whatever these tools were, but now everyone is not only has Zoom, but they're confident with its utilization, right? I mean, of course, we're still trying, somebody said yesterday, I wish I could go around and mute people in the vendor hall that I didn't want to listen to. But other than that, unfortunate, just, unable to occur. We've had the opportunity to bring these technologies into the spaces, and I think that for those laggards on the technology adoption scale, those folks that won't do things unless they're required to, they have to, it's shown them how easy these tools can be, not only at the individual level, but at the systemic, hospital level or the institutional level, and that's leading to greater opportunities to kind of have a better work-life balance. And actually, I think in some cases, you're probably going to get more efficiency out of people. I mean, if we're spending an hour driving to work and back every day, that adds to not only our costs, but how much energy do we have available each and every day as opposed to being able to work from home. Folks, I've known the secret about working from home since 2012, but I'm glad you're all catching up to me from
10 years later. Yeah.
But Elizabeth, how about for yourself? Any institutional changes that you've seen over the past 2 years for the better?
I don't think we've really had a whole lot of institutional changes. we've been fortunate. We had a new dean that came in a few years ago and noticed really what we were already doing with simulation, and so she helped to support us in getting provisional accreditation for our center. And so that really has kind of been where a good part of our focus has been over the last 2 years. So we just received our plaque for
congratulations.
provisional
That's so
accreditation, and so
awesome.
now all the work really starts. But having that support, I think, has helped us also lift the simulation center, because my focus is nursing. And so now we're kind of bringing it up with the College of Medicine and College of Pharmacy, and so we're really hopefully going to start getting that more interprofessional communication and the things that we really should be doing in our simulation center. We should all be practicing with best practices and making sure that we're doing things the right way. So I think in that sense, that's what's helped in the last 2 years, bringing that recognition by not only her, but the other deans in the institutions and within the health sciences as well.
Right. If you build it, they will come kind of mentality. And so I think, you know, an adage that I like is from real estate, where they say the buyer has no imagination. And so in a sense, you know, that means you can't leave the house unpainted. If you want to sell the house, you got to paint the house. And same thing, I think, with things like virtual reality, or just the concept of simulation as a tool anyway. I do remember at the institution, the Nevada System of Higher Education's Clinical Simulation Center, I was the director. The faculty and myself were trying to convince one of the pediatric instructors about the power of simulation. And we were talking to him, we were blue in the face. Until we had that open house and he saw a pediatric simulation scenario running from the other institution, it was like the light bulb went on, and we couldn't stop him from coming in and using this. We had to like, well, wait, there's a process here, we can't, you know, I mean, it was just so much interest and energy. And so I think these types of opportunities, they bring about, you know, just that accreditation, that's a real big deal. It shows that the School of Nursing has really made an investment. They have met standards that become accredited, and that can expand into other institutions and show them, hey, wait a minute, we're the medical school, we don't have any of that. Well, what's going on over there? My only you know, request for you is to make sure pay to play, right? People groups can't come in without the consideration of what the budget is going to do. So, oh, well, we donated this piece of equipment 15 years ago. Yeah, that's gone, right? So, you know, make sure that when we have this awareness, and if you build it, they will come, you're going to have to be prepared to kind of make sure that we operationally are able to handle those things, and we're going to be able to handle that influx, and where the money's going to come from. It can't come out of the budgets already that are allocated for the performance we have now. It's got to come from somewhere else if we want to expand with new staff and new programs.
Yeah, absolutely. Yeah.
All right, so Shannon, institutionally for UW, what have you guys had the chance to kind of expand and grow into?
Yeah, so that's so I first want to recognize the privilege that I have at UW-Madison and UW Health, where I work, that we never shut down at all for the pandemic.
Wow.
You know, they said to us, you are so important to our institution, and that goes to our great staff that we have in the Sim Center. It has nothing to do with the work that I do. It has to do with the team that I'm working with all the time.
And so I've toured that space, and it's an amazing program with an amazing team, and so many different schools. There's pharmacy, right? And so we're very
lucky.
Robust.
Yeah, very robust, and I recognize the privilege that we have in that conversation. But so we didn't close down the pandemic at all, but what we did do was kind of prioritize continuing that education. And one thing that we did, a colleague and I, that we'll be presenting on later on this week, again, shameless plug, is on our team steps that we worked on in the OR. So there's a team steps initiative at our OR right now that they just couldn't get to go to the next level. They were doing it without simulation, and I had a conversation with one of the directors of ambulatory services and peri-op services, and they said, we really want to try to bring simulation into the OR to help with these team steps initiatives. And then the pandemic hit, and we ended up having to shut down a lot of the elective surgeries, as most people did around the world.
Sure.
But they said, we want to still prioritize doing these education once a month, and we want to have these communication and teamwork sims still occur, because we recognize how valuable it is.
Right.
Not only 2 years later are we still doing those sims, but we're still expanding it back to the ambulatory services as well, and bringing more team steps and more communication-based, teamwork-based simulations out to those groups, because they recognize the priority and the importance of that kind of work. So we feel very lucky that that initiative not only has taken off, but it's expanding beyond what we could have ever imagined it to be.
And a large portion of the errors that are taking place in regards to medical error are because of miscommunication, right?
100%.
Medication administration is one major area, and communication is another. So I think that the institution has seen the importance, and even during the pandemic wanted to prioritize those as best as they possibly could to make sure that that training, because they knew that those outcomes were going to be improved or sustained at the higher levels. And if we let go of that training, even once a month, it's just enough to help. Again, that just-in-time training, that continued training, it's never a one and done. it always has to be a continual process of education and training and retraining on a regular basis. You know, pilots are regulated and mandated to have specific simulated training. The simulators themselves are regulated and mandated because they're so realistic, but on a consistent basis. My uncle flew for Air Italia, and every 2 years he had to go and do a demonstration flight with somebody on board, even if it was during an actual commercial flight, to do specific drills. And we don't really have too much of that when it comes to actual skill demonstration. You know, we do CEs and we go and sit and attend, but where's the demonstration of those skill sets, much like they have in aviation, right? This need. And I think our industry is going to move closer and closer to those trends. We're seeing calls now around the country for a national patient safety board, similar to a national transportation safety board. Of course, you know, they have the FAA to enforce those rules, but hey, if we could even get started with something like a national patient safety board, I think it would help to bring more awareness to these issues and help to create a standardization of the type of work that we're doing. Well, thank you so much for joining us here today and for sharing some of your success stories. You know, I think it's so important that we spend some time talking about the good things that have happened around the world in the past couple of years, because there's been so much strife for everyone. So again, thank you for you all for sharing, and thanks for joining us. We'll see you all at the next one.
Thank you.
Thank you.
Thank you.